Hi, I'm happy to be here, and by the end of this talk, I hope you'll be able to understand how to measure sarcopenia. All right, so just an outline. So I'll go over first some background and terminology to make sure we're all using the same words to describe the same thing. I'll talk about the development of some sarcopenia definitions and then review some new approaches. All right, so we know that in everyone, muscle loss occurs with age, even when you exercise. So this is a picture of a man named John Turner. In this picture, he's 67. He looks very fit and strong. Here's another picture of him. This is about 12 years later, and you'll see that despite exercising and even with heavier weights in the second picture, he's still losing muscle. He's lost muscle definition. There's probably some changes in terms of body composition for adiposity, etc. So even when you exercise, we know this happens, and this goes to Gustava's point that there's sort of a normal loss of age, muscle that happens with aging, and then also probably a potentially pathologic loss of muscle, and that's what we like to describe as sarcopenia. All right, so sarcopenia, the term sarcopenia came into our nomenclature in the 90s. It's a little bit of a debate, I guess, of who actually coined the term, but basically it means a poverty of flesh. And there isn't a single consensus definition yet for sarcopenia, and I'll get into this, why that is in my talk. But basically, early definitions of sarcopenia rely just on proxy measures of muscle size. But more recent and modern definitions of sarcopenia include measures of strength or function in sarcopenia definitions. All right, so let me pause here and just describe the terminology that we use in the field of sarcopenia. So there's a number of different ways that we either measure or approximate muscle size. Gustavo earlier showed data from lean mass from DEXA. You can also derive fat-free mass from impedance analyses. You can get cross-sectional area from CT or muscle volume from MRI, and then D3-CR muscle mass, which I'll talk about later, from the D3 creatine dilution method. There are also even more approximate measures through, say, skin calipers or calf thickness that can approximate muscle size as well. Then we have measures of physical performance, and these are things that are integrative measures of how people move through the environment and include things like chair stands, walking speed, time up and go. These are measured and are objectively assessed. We have direct measures of muscle function. These are generally strength and power. And then self-reported function, which is how people perceive their ability to function. And these can generally be considered limitations or the frank inability to do something or disability. All right, so strength and performance, just some background on common measures and how they're related to outcomes. So strength is very commonly measured in studies, particularly grip strength. And the reason why grip strength is measured compared to other things is that it's really cheap and easy to do. A handheld dynamometer is about $250, and the measurement protocols take 2 to 3 minutes. You don't need any other special equipment. They're generally very precise. And importantly, they also measure risk of poor outcomes over time. So this is a paper from the Honolulu Heart Study that shows that folks who had measures of grip strength in midlife were associated with poor outcomes in older age. So those with the highest grip strength had the lowest risk of having self-reported difficulty with doing a number of ADL and IADL tasks. They also had much faster walking speed and ability to rise from a chair than those in the lowest tertile. And these data have been repeatedly shown. Why grip strength is related to your ability to rise from a chair 25 years later, no one thinks, well, unless you read a New York Times article about grip strength being related to things you can train your grip strength. No one's thinking that it's grip strength per se. Grip strength is thought to be a surrogate marker of overall body strength and muscle function. I do not recommend just squeezing the little exercise thing. There's stress balls we got. That's not going to prevent outcomes in old age, but it might make your osteoarthritis in your hand hurt. All right, let's see. Performance. So the classic measure of performance that many studies have is walking speed. Walking speed obviously is a very integrated measure of not only muscle function, but neurofunction, cognitive function, balance, pain, etc. And there's strong evidence that walking speed is strongly predictive of mortality. So this is another famous paper using data from a bunch of different cohort studies that shows that as your grip strength declines, so you go from the top line, that's the fastest, to the bottom line, that's the slowest, that your risk of your median survival decreases as your walking speed goes down. And this is true across every age, and even amongst the oldest old, the faster you walk, the longer you'll live. So it's another great marker to measure how people are moving functionally. All right, so as I said, grip strength is really easy to measure, but why do we measure it? It's really a practical reason. Lower extremity strength is actually quite difficult to isolate and measure. The common measures of leg extension, strength, and power, the cheapest machines are in the several $1,000s range, all the way up to $50,000. Those protocols tend to take a long time. It's also difficult for older people who have impairments to get in and on and off some of the leg strength measures. And so while if you're interested in mobility per se, it would make sense to have a lower extremity measure, they're often very hard to do. And that's the same thing about power. Power is a measure of how quickly you can generate force, which is more proximally related to functional outcomes like falls, for example, but it's very difficult to measure that reliably. Now, when I say grip strength and walking speed are great measures, walking speed also has a bunch of different flavors. It's a short distance walk, a long distance walk, a very long distance walk, a timed walk over a longer distance, for example, the 6-minute walk. And then there's integrative measures of physical performance, like the short physical performance battery and the timed up and go. And so which one of these measures you use really depends on the hypothesis you're trying to test. And I'll get into what is included in the sarcopenia measures in a minute. All right, so muscle size. So muscle size and lean mass, as I said on my terminology slide, there's a bunch of different ways to do this. One approximation that's been commonly used is dual X-ray absorptiometry, or DEXA, which I'll talk about in a minute. There are a whole host of imaging measures to approximate muscle size, and these can measure muscle cross-sectional area or volume, muscle density, which is a marker of fat infiltration on CT, or percent fat fraction from MR, and then other methods like BIA. So let me talk about DEXA for a minute. So what does DEXA measure, if you're not familiar with it? It's a 3-compartment model. People lie on a bed. There's a dual energy X-ray that's exposed to the whole body. And it's over the course of the scan, the absorption of the 2 different X-rays are measured. And from that, imagining this as your body, DEXA directly estimates your bone mineral content, so that's all the bone in your body, your fat mass, that's all the fat, and then by subtraction, everything else is lean mass. Now, that everything else of lean mass includes water, protein, skin, fibrotic tissue, everything that's not fat or bone, including any collagen or structural material that's in fat, like adipose tissue, for example, that would be counted as lean mass. And so lean mass is not a direct measure of muscle. Although muscle mass is the largest component of lean mass, there are a bunch of other things in DEXA for lean mass that aren't actually muscle. So it's not a direct measure of muscle mass, and so this slide really should say that DEXA is measuring lean mass, not muscle mass. Now, why does this measure? Is this just a semantics argument, or does it make a difference? Well, it turns out that when sarcopenia was one of the first operational definitions that was developed by Baumgartner, it was actually fairly clever. They had a bunch of DEXA scans, and they used the appendicular skeletal muscle mass, which is actually appendicular lean mass, and divided it by height squared, and then used normal values from young adults to determine if you had sarcopenia, yes, no. The appendicular lean mass is just the sum of the lean mass in the arms and legs, acknowledging that most of the lean mass in the abdominal compartment is probably organ weight, right? Lungs, liver, et cetera. All right, so what did they find in this study? Well, this is a little bit small, but they found that generally those who had sarcopenia by this definition were more likely to have disability or gait imbalances. However, the values were actually imputed for about 3/4 of the participants using age and grip strengths in their imputation model. So it was really unclear, even in this first paper, if lean mass was related to functional outcomes. Since this paper was published, there have been a number of meta-analyses and individual papers that have showed that DEXA lean mass is largely unrelated to outcomes. And other studies, particularly in intervention studies, have shown that there is a disconnect between lean mass and changes in lean mass and changes of strength. So there are a couple of intervention trials, for example, one in knee OA, and then a study of resistance training and people taking a diabetes drug, pioglitazone. And those folks lost weight, lost muscle mass, lost lean mass, but they had a dramatic increase in strength despite their muscles being smaller. We've also seen that anabolic agents to increase lean mass, for example, selective androgen receptor modulators, greatly increase lean mass. So here on the left, you'll see that the treatment group, the top line, had a really marked increase in lean mass with no, limited change in the placebo group. But then the changes, that's in strength, but the changes in lean mass between the groups were similar. So again, how can strength increase when muscle mass or lean mass isn't? So why does this matter? Well, and what's an explanation? Well, one explanation that many people took from this literature is that muscle size doesn't matter. Epidemiology and measurement error might tell you that if you are measuring something with error, generally this will result in bias towards the null or seeing no effect if it's non-differential in terms of the outcome. It's even more problematic if the error is differential, but because DEXA lean mass is likely to be subject to measurement error, it's likely why the previous literature had suggested that muscle may not be important if you're using lean mass as a proxy. All right, so let me go into where the field went with that for defining sarcopenia. All right, so if there is a disconnect between lean mass and outcomes and strength and performance, how do you integrate all of these into a single definition? So people have really come to believe that sarcopenia is a complex syndrome that reflects both a decline in muscle size over time, but also declines in performance and strength, and therefore may be more closely related to things like dementia or incontinence than to, say, neoplasm. And unfortunately, there's no gold standard outcome to evaluate any diagnostic criteria for sarcopenia. For example, in osteoporosis, you can say, oh, does this condition definition accurately identify people at risk of hip fracture? Well, in sarcopenia, what's the muscle outcome? Is it falls? Is it fracture? Is it death? Is it hospitalization? Is it disability? All of these are really hard because those outcomes I just listed are so multifactorial. It may not just be muscle or muscle loss over time that causes them. All right, so there's several competing definitions for sarcopenia. I'm not going to go into the detail of these, just to show the highlights and the similarities and differences. So the similarities of all these consensus definitions is that they all consider sarcopenia to be a multi-component syndrome that include at least a proxy of muscle size, except for the SDOC, which I'll get into, and other factors. But then they have really important differences. When cut points for each component are included, they're different. They have different measures, and then they have different measures for specific components, for example, for what is considered low physical performance. So it's really difficult to synthesize the literature across these definitions. Here's an example of a European working group definition. So they have 3 components, starting with low muscle strength, then low muscle quantity or quality, and then finally low physical performance. And from these, they consider people having probable, confirmed, or severe sarcopenia. Now, a challenge with this definition is that it uses a number of different proxies for each measure. So low muscle strength could be determined by grip strength or chair stands. Low muscle quantity or quality could be determined by all these factors, and low physical performance by several other factors. So you can see that this algorithm could have one person classified as sarcopenic if you use some of the measures and not sarcopenic by other measures. And what this leads to then is, depending on the definition and how it's used, hugely varying prevalence of sarcopenia by the definition employed. In this meta-analysis, where this PhD student included something like 128 papers, found that the prevalence of sarcopenia, depending on the definition, varies from 10 to 40% in older adults. That's not the same condition in the same general population. So it shows some of the challenges with definitions of sarcopenia. So do these sarcopenia definitions predict outcomes? Oh, I deleted a slide to save time, so I'll skip that part. The main point is, yes, they do, but it's hard to disentangle which pieces of the definition are most important. So we were involved in an effort to define sarcopenia called the SDOC, and the goal here was to try to bring some different groups together to understand how we can define sarcopenia. And it was a position, we had a position development conference where we highlighted where there may be some controversies in the field. We had an expert panel, which included people from academia and industry, to help us determine what the main outstanding issues are in defining a definition for sarcopenia. And here's the group. They were actually very deliberative and contemplative and collaborative, which is maybe foreign to the folks right over there in DC. But they listened to each other and really did try to reach compromise. And they evaluated a whole set of statements, which I won't go into, but the main point is that they found that they appreciated and agreed that physical performance and grip strength are largely important to include in definitions of sarcopenia, but given the challenges with lean mass and its poor association with outcomes, that DEXA should probably not be included in a definition. And so based on these comments and the input from this committee, the SDOC definition then included just low grip strength and slowness and no measure of muscle size. So on the one hand, that's satisfying because you've eliminated the component of sarcopenia that is problematic in terms of measurement, but then you have a disease that's the poverty of flesh that doesn't include a measure of muscle size. So did we back ourselves into a corner here by not having a measure of muscle? All right, so there is effort still to harmonize all these definitions over time. We've decided on common terminology to use and have published a paper about this, which was not a huge point of agreement, but we did all, a point of controversy, but we were all able to come together. We've initiated a Delphi process to develop a conceptual definition, and now we're working on an operational definition. That will be a process. And the point here is that it's not just, it's bringing together all of those working groups that had developed the other terminology. So for this part, stay tuned. All right, so I'm going to skip this in the interest of time and talk about another measure of muscle mass that holds promise. So we've used this D3 creatine dilution measure in our studies, and if we're able to measure muscle mass directly, then maybe more complex measures or definitions of sarcopenia may not even be needed. All right, so as I told you earlier, DEXA is precise but not accurate, so it does not directly measure muscle mass, and we posit that D3-CR muscle mass is both precise and accurate. So how does this measure work? All right, to understand this measure, you need a refresher about creatine biology. So nearly all the creatine in your body is found in muscle at a relatively constant concentration. So if you're able to estimate how much creatine you have in your body, you're able to have a good estimate of how much total body muscle mass you have. We also know that creatine is converted to creatinine at a constant rate, and you can determine creatine pool size from a 24-hour urine. However, in older adults, that's really, really hard to do. You have to have strict dietary control because you can't have any creatine or creatinine from meat in the diet. There's timing issues. If you have incomplete bladder opening, emptying, or incontinence, this measure won't work. So let me tell you about operationally how this protocol works, and then I'll go through how we calculate the measure. So to do this measure, we orally dose people with 30 milligrams of deuterated creatine, where deuterium replaces some of the hydrogen in the creatine, so you're able to tell on a mass spec the difference between labeled and unlabeled creatine. Then 3 to 6 days later, you take a fasting spot urine, and from that, you'll measure the ratio of labeled to unlabeled creatinine in the urine. While this is happening, all the creatine in your body is being converted to creatinine, and all the labeled creatine in your body is being converted to labeled creatinine. All right, there we go. We dose. Once they reach isotopic steady state, we take a urine sample. All right, so here are these two guys. The guy on the left has more muscle mass than the guy on the right. So the guy on the left has a greater creatine pool size, and so he has a lower ratio of labeled creatinine to total creatinine in the urine. The guy on the right has a smaller muscle mass. He had the same dose of labeled creatine. He has a lower creatine pool size, so relatively more of his creatine and relatively more of his creatinine in his urine will be labeled. So from this ratio, we back calculate how much muscle mass someone has. It's been validated against MR muscle volume in humans, and it's strongly correlated, and it shouldn't be influenced by renal function, medications, or diseases. As long as you're producing some urine, the ratio of labeled to unlabeled creatine should be unaffected. So how does this relate to outcomes? So we've used this measure in Mr. Ross, which is a study of older men who've been followed for many years. It was and these data include about 1,400 men who are all in their mid-80s when the measure was done. They had D3 creatine, they had appendicular lean mass by DEXA, and a whole host of physical performance and functional outcomes. We found, as we expected, that D3 creatine and total lean mass by DEXA would be correlated, but they're not measuring the same thing, as they don't fall in the same line of identity. DEXA overestimates muscle mass, just as we would have hypothesized. When we look at quartiles of participants characteristics of participants by quartiles of D3-CR muscle mass to weight, we see that those with the highest muscle mass, the column labeled quartile 4, they tend to be the youngest, they weigh the less, and importantly, they have much faster walking speed, much higher short physical performance battery scores, and much stronger grip strength. We also see that D3-CR muscle mass is associated with incident self-reported disability. So for each standard deviation decrease in muscle mass, the risk of either ADL, mobility, or IADL disability is increased by about 1.5 to 2-fold. We see that D3-CR muscle mass divided by weight is related to mortality. So those in the lowest quartile, the red line, have much higher mortality than those in the highest quartile. It's an odds ratio across quartiles about 2.5. We also see that those with lower D3-CR muscle mass have a much higher risk of hip fracture. The risk of hip fracture across quartiles of muscle mass is about 6-fold. So those with the lowest muscle mass are about 6 times more likely to have a hip fracture. We've also looked in the SOMA study at the D3-CR measure. A limitation of Mr. Ross is it's all men. SOMA includes men and women. SOMA is a study with a whole bunch of markers of aging, at 2 clinical centers. My group serves as the coordinating center for this project. And we have a million things we measure. If you're interested in knowing more about SOMA, I'm happy to talk about it at a break. But basically what we found is that the results we've seen in Mr. Ross are recapitulated in the SOMA study. So in the far left-hand column are the relationships between D3-CR muscle mass and leg strength, leg power, 400-meter walking speed, and VO2 peak in men. Then the next red column is the relationships between total thigh muscle volume by MR and those outcomes. And then the two columns on the right are for the same results in women. There does appear to be a slightly attenuated association in women than there is in men, which I don't totally understand if it's a problem with the measure or a difference just in inherent muscle biology, but we do see that results are similar in women. All right, so to summarize this part about the D3CR muscle mass assessment, we know that it's strongly related to mortality, strength, physical performance, and function, and this may be stronger in women. So could this measure be the measure of sarcopenia? And we wouldn't need to include measures of function. The results I showed earlier for the incident outcomes were all adjusted for current physical performance and strength, which suggests that even when you know physical performance and strength, muscle mass itself by this measure could be possible. My answer is maybe. I don't think we have enough data. We need to know how it responds to randomized controlled trials and particularly other more diverse populations. I do acknowledge this is a somewhat complicated clinical measure with a time, dose, and collection, but we do ask people to do things that are very complicated clinically. For example, colonoscopies are very challenging, but those are universally recommended for screening. So I think this is a watch this space kind of issue. All right, so the final thing, the recommendation, how do you measure sarcopenia in HIV studies? The major thing is to measure the components separately so that you'll have flexibility to use whatever definition comes up, and consider several different domains, including direct measures of muscle function, muscle size, physical performance, self-reported function and disability, and perhaps even fitness, such as VO2 peak. All right, with that, my acknowledgements, and I'd like to particularly acknowledge Bill Evans and Mark Hellerstein at Berkeley, who developed the D3 creatine dilution method, and I'll take 2 more seconds to say we're always hiring postdocs, so if anyone is interested as a postdoc or knows a postdoc or is friends with a postdoc, have them come talk to me, because they're hiring. Thank you.